Now we're going to discuss the Madelung Deformity. Clinical presentation is usually an adolescent wrist with a deformity. They have a prominent ulna, usually female and often asymptomatic. Now, making the diagnosis is difficult, and I see a lot of misdiagnoses. You must have, in order to be a true Madelung's disease, growth restriction of the volar ulnar corner of the radius, increased radial inclination, Lunate Subsidence, and the presence of a Vicker's ligament. Otherwise, it is not a true Madelung's disease, but something akin to a Madelung deformity, which is similar. Causes of the deformity: Léri-Weill dyschondrosteosis is a mesomelic dwarfism with short stature homeobox gene mutation. It is autosomal dominant inheritance. They also can have tibial bowing, scoliosis, high arched palate, and interestingly increased muscle mass. Now, the other things that can look very similar is a gymnast wrist. Whereas Léri-Weill dyschondrosteosis will have a Vicker's ligament, a gymnast wrist will not. It's just a physeal arrest of the volar ulnar corner of the distal radius. You can also have post-traumatic physeal arrest that can look very similar, and you can have multiple hereditary exostoses, which can look very similar. Here's a patient with Léri-Weill dyschondrosteosis, and you can see on the upper right side the family, all of them having the deformity. And notice that in Léri-Weill, most patients have bilateral disease, and I would say it's the rule rather than the exception. Growth arrest can also cause a similar appearance, or that can be caused by multiple hereditary exostoses, growth plate arrest, or gymnast wrist, as I said, but you will not see a Vicker's ligament. Therefore, it's not a true Madelung's disease. True Madelung's requires a Vicker's ligament. This is an anomalous, hypertrophic, short radial lunate ligament. The ligament emerges from the metaphysis and not the epiphysis, and therefore it does not grow with the distal radius and becomes a tether as the ligament crosses the wrist. Here you can see it quite clearly on this surgical case. It's very similar to focal fibrocartilaginous dysplasia, which occurs in the distal ulna and looks exactly like a Vicker's ligament, both grossly and in histology. Physical examination demonstrates a prominent ulna. Wrist flexion is greater than wrist extension, and there are signs of ulnar abutment before the ulna escapes. Once the ulna escapes, you don't see really ulnar impingement type symptoms. Imaging studies include plain x-rays, although advanced imaging studies can be very helpful in visualizing the Vicker's ligament and determining whether you have a true Madelung's disease or a Madelung's type deformity. Plain x-rays will show you a notch at the medial radial metaphysis, so-called flame, and there's increased radial inclination, increased volar tilt, and again subsidence of the lunate into that space. Other radiographic parameters include ulnar and dorsal curvature. There is a variant called whole radius involvement where the TFCC is stronger than the proximal radial ulnar joint ligaments, and the radius gets pulled along with the ulna, so the ulna never becomes ulnar positive. It just takes the radius with it. Normal ulnar and ulnar variants, there's a gap at the radiocapitellar joint, as you can see between A and B. These tend to be less symptomatic at the wrist, but obviously more symptomatic at the elbow. There are a whole variety of measures that have been described to determine the severity of the Madelung's deformity, including ulnar tilt, lunate subsidence, lunate fossa angle, Palmar tilt, and Palmar carpal displacement. Here's an example of how to measure ulnar tilt, defined as the complement of the acute angle between the longitudinal axis of the ulna and a line drawn at the base of the lunate and the scaphoid. Lunate subsidence is a distance in millimeters between the most proximal portion of the lunate and the line perpendicular to the long axis of the ulna. It is positive if the ulna is distal to the lunate. The lunate fossa angle is the complement of the acute angle between the longitudinal axis of the ulna and the lunate fossa of the radius, as seen here. And then there's Palmar carpal displacement, which is the distance in millimeters between the longitudinal axis of the ulna and the most volar surface of the lunate or capitate. The complement of the acute angle is the Palmar tilt between the longitudinal axis of the ulna and the articular surface of the distal radius. And then advanced imaging studies, as I said, show you this Vicker's ligament. If it doesn't have a Vicker's ligament, in my opinion, it is not a true Madelung's deformity. Treatment is generally observation for the mild asymptomatic deformity, and you can follow these patients if their deformity is mild. However, if they're skeletally immature, and by that I mean premenstrual, and there's progressive or mildly symptomatic disease, or even a history of family disease, or if the patient has Layard-Weill dyschondrosteosis, I would go ahead and release the Vicker's ligament as soon as I see the patient and can get it scheduled. Here's what it looks like. Just release the Vicker's ligament, and again, there it is on the left. However, generally they do not present early, they present late once a deformity is quite severe. Therefore, if they are symptomatic, which means painful or they don't like the appearance, then I would say that you have to do something. The dome osteotomy, there's a happy face and a sad face osteotomy depending on which direction you make the dome. We like to make a sad face dome so we can avoid the distal radial-ulnar joint ligaments, but it's primarily been described as a smiley face. The Vicker's ligament should be released and then assess the ulna to see if you need to shorten it. So basically, number 1, ligament release, number 2, dome osteotomy, and here's what I mean by smiley face. This is the more typical osteotomy, which is concave facing upward. The way we like to do it to avoid the distal radial-ulnar joint is to do the osteotomy in the opposite direction. Then there's the reduction, the pin fixation, and excision of the volar lip. Here's an example of what it looks like. We have started doing a lot of 3D modeling for severe deformity. We use a company called Materialize. I have no ties to the company, but the Materialize company has done a great job of modeling this for us. Here's an example of a case where the hand was on sideways and we were able to do this osteotomy and I think get pretty close to the planned correction. For the ulna, we do ulnar shortening and an ulnar epiphysiodesis if we want to stop the growth and re-level the joint. Outcome overall is variable for Vicker's release. Some people have reported good outcomes for Vicker's release, and I suspect that that has to do with age and severity of the deformity. I think if the distal radial physis has already undergone irreversible arrest, there's nothing you can do to change that. A dome is a fairly reliable correction, and I would say that in our hands, we've gone further and further and further into doing 3D modeling, depending on the severity of the deformity. If the deformity is fairly simple and we think we could do it with a simple dome, we'll just do that. But if it requires multiple osteotomies of the radius or a shortening of the ulna, then we'll go ahead and do 3D modeling. So thank you very much. For more information, visit littlearms.org.